So now we have heard quite a lot about the basic construct for nociception in the musculoskeletal system. What I will try to show you here is how can we actually activate this system in humans and be a bit more specific on the manifestations when we have this, activated this system. I know that Hans-Georg mentioned that it will give pain and many other things, but fundamentally what he showed was activity in the nervous system in most of the slides, nociception. But what we'll try to show here in contrast is that how can we excite this system. So outlined in another way, then we have learned now that we can have changes in the periphery. We have also many different types of changes in the central nervous system when we have ongoing pain. This is defined as either central sensitization. I've started to use central facilitation instead of, because central sensitization is a very discussed phenomenon nowadays. But fundamentally, many of the central mechanisms can be facilitated and, of course, change the way that pain is manifested in the system. And then finally, a very important thing is also how the supraspinal system will change the way that it controls the incoming nociceptive information. So fundamentally, all these different processes will be active in patients when they present with either localized pain or regional pain or widespread pain. It's just a matter of what is the ratio, or what is how much of the peripheral sensitization is active and how much of the central components is actually relevant and active. And this depends on many different things, and I don't think we have the answer right now, but it is just important to realize that we have all three different components in play, both the peripheral sensitization, the central sensitization, and also changes in the descending control, which will give this manifestation of pain that the patient will present. So you can also see that whatever the patient will report is a composite of many different things: localized pain, referred pain to other structures from the injured side, widespread hyperalgesia, localized hyperalgesia, and many other things. And what I will try to do here today is that I will try to outline different mechanistic assessment modalities and techniques from which we can actually start to be a bit more specific on the manifestation. And the first thing that I will give you some introduction to is hyperalgesia, especially the widespread hyperalgesia, because this seems to be very important for the central changes. Then I will tell a little bit more about three different central mechanisms. At least the first two will be defined as a central mechanism, where we have temporal summation of pain from the deeper structures, which is actually giving very important information on the sensitivity of the central system. And also referred pain, which can be a window into understanding the sensitization of the central system. And then finally, we also have the descending pain control, which can be assessed. And actually, just in the neighbor room, they're running a full session on this from a more general perspective on how can this be assessed. But I'll try to focus on how and what have we learned from assessment of the descending pain control in musculoskeletal pain. So it's actually very simple what we can do in humans. We have to be very careful on what we do. We do not make any harm to the patients or subjects. So we are very simplistic in the way that we think that we can induce pain and we can assess pain in a very standardized way. So we have to get the response from the patient or from the human subject. And we have to go for example, pain thresholds or specific pain ratings or whatever. Where we can be a bit more intelligent is the way that we actually excite the system. And from a practical point of view, we can use many different modalities, which is reflecting the various modalities you saw in the first slide from Hans-Georg Scheibel, where we have the different modalities. So we can fundamentally excite these deep tissue nociceptors by chemical stimulation or by mechanical stimulation, and also, of course, by electrical stimulation. And actually, we can also do thermal stimulation, but as also was said previously, we don't know really how relevant that is, so we're not focusing very much on that. Today, I will focus on chemical stimulation and mechanical stimulation. And we can do exactly the same thing in patients, and here we will then be able to target particular mechanisms and understand the sensitivity of these mechanisms. And please note this color coding, because at all the slides that you're going to see today, you will see either this very green spot here on the top of the slide, or this one indicating if we are somehow working on illustrating a particular pain mechanism, or we are showing some patient data. So let's get started with mechanical excitation of the deep tissue nociceptors. Many of you know that we have a very good and reliable technique called pressure algometry, illustrated here, where we can assess, for example, pressure pain thresholds or assess the tolerance to pressure stimulation. This has been shown in many studies that it's reliable, but there are actually issues to consider when we are using this setup here. Because when we do pressure stimulation, then we actually have to consider a little bit about what do we stimulate. Of course, we know that we will excite the deep tissue nociceptors, but we were very surprised when we did a study where we tried to, by computer simulations, estimate how deep do this pressure strain actually penetrate into the tissue. So what you see here is how much the tissue is strained by pressure stimulation equally to the pressure pain threshold. This is a cross-sectional area of the tibial anterior muscle. And from my previous work, I was convinced that when we did pressure pain stimulations at the TA muscle, then we definitely strained or compressed most of the TA muscle. But what you can see here is that it's only the very superficial part of the TA muscle which is stimulated when we are having an intensity equal to the pressure pain threshold. And this is in healthy subjects, so the pressure stimulation is actually quite high. So what is going on when we stimulate patients where we have very low thresholds? That's still up for discussion, because my point here is that we do not stimulate the very deep structures. So we have to be careful when we are evaluating what to assess. So if we have some very deep structures we would like to evaluate, we probably have to do something else. We can try to optimize how much we stimulate, for example, by changing the geometry of the probe, as illustrated here, where you can see much larger aspect of the muscle is stimulated, but still it is only the superficial 1 to 2 centimeters which is really excited here. Anyway, when we do this, then of course we stimulate both the skin and the deeper structures. And this has been up for discussion for a long time, what was actually activated when we did pressure pain stimulation assessments. So we did a study, it's a fairly complicated study, but where we had a pressure device where we could slowly increase the pressure intensity over time, and we could ask the subjects to rate the pressure pain sensation on this visual analog scale. And before we did anything, we of course had a baseline recording, so you could see that it became painful when we had a pressure intensity around 8 to 10 kilos stimulation. Then the first thing we did was that we tried to anesthetize the skin completely. And what you can see here is that we actually had a short, relatively little right shift of this stimulus response function, meaning that the input from the skin was not very important for the sensitivity of the pressure stimulation. If we instead of started to block the deep tissue nociceptors by an ischemic block, then you can see that slowly we got more and more, less and less pain sensation when we had a complete block of the system. So illustrating that the pressure stimulation on the top of the skin will definitely give input from the deeper structures. Not a surprise, but just very important to verify. So pressure algometry is useful. We will get pressure pain thresholds, but how can this now be used? Well, for example, it's very important, as we have somehow indicated, to look for the widespread sensitivity changes. And one way to do this is, of course, to do stimulations on many different sites on the body. And here you see an example from a study where they have looked at different types of neck pain, either whiplash or idiopathic neck pain or controls, and I'm sure you will see more of this category of studies later on when Michel Stalling will present. But what you can see here is that what is interesting is that if we look at the site very distant from the actual injured structures, then they have a reduction in the whiplash-associated pain patients, but not in the idiopathic pain patients, but in the neck area, of course, the pressure pain thresholds were very much reduced in both categories. Just to illustrate that the protocol, the design of the protocol is fundamental for getting the right information from when we use Algometry, because by that, we can actually start to ask questions. Simply by having this very distant point, we can ask questions about what is the central changes. So, for many years now, we have actually used the osteoarthritis patients as a model to understand what is happening now for when we have an ongoing input to the pain system for a long time. So we have used pressure algometry, and we have done studies where we have evaluated the pressure pain thresholds around the knee and on distant sites on the tibialis anterior muscle, but also on the arm. And when we do that, we will get some nice illustrations indicating for the individual patient, for example, that this patient is very sore on the knee. Again, this is definitely not a surprise. We have knee pain patients that have reduced pressure pain thresholds compared to control subjects. But what is interesting is if we start to look at these very distant sites. Here you see the pressure pain thresholds at the very many spots around the knee, but also at the distant sites here. Here you can see that on the arm and on the tibialis anterior muscle, the osteoarthritis patients actually demonstrated significantly reduced pressure pain thresholds compared to matched control subjects, illustrating that it's not only very localized sensitization phenomena that we are looking at, it is also some central changes. The same thing we recently showed in hip osteoarthritis patients, where again we had assessments around the hip, but also on the tibialis anterior muscle and on the arm. So it definitely seems that the central system is facilitated, or we have hypersensitivity at other sites, which is outside the actual point of discussion. So definitely pressure algometry can be used if it's used in an intelligent protocol where we have both assessment of sites where we had a potential injured area and also outside these areas. I mentioned in the beginning that we're not so happy about the depth of the stimulation by pressure algometry, so therefore we have actually started to use another modality called Cuff-algometry, and you'll see later on that here we get actually a very efficient deep stimulation. Cuff-algometry is a very simple approach where instead of using the pressure algometry, we use a tourniquet or a cuff which can then be inflated automatically, and then the subject can rate the pressure pain sensitivity from the cuff on this visual analog scale, or we can assess the pain threshold, how much cuff pressure is needed to elicit pain, and how much is needed to elicit the tolerance. And when we do that, we actually get a much better compression of the deep structure and a much better excitation of the deep tissue nociceptors. Here you see the same type of computer simulation models, where we here have an illustration of the cross-sectional area of the lower leg below the cuff, and you can see this is for strong, something which is felt like a strong pressure. This is a strain. You see in those two sections here. Here we have the pressure equivalent to the pain threshold, and here you have something which is equivalent to a suprapain threshold stimulation. And you can definitely see that now we stimulate a large proportion of the deeper structures, which was not the case for the simple normal pressure algometry. So we definitely have a very good excitation of the deep structure by this setup. One disadvantage, and that's completely clear, is that it can only be used on extremities, not on the trunk settings, where we also have a very important need for assessment. So again, when we do this, then we can assess in, for example, the hip osteoarthritis patients, we can demonstrate that if we look at the pressure in the cuff versus the VAS rating, that in controls we have this stimulus response function, and then in the osteoarthritis patients we actually have a very nice left shift of the stimulus response function. In fibromyalgia patients, this has also been used, as illustrated here, where we have a very significant reduction of the pressure pain thresholds, both on the thresholds to the cuff stimulation and also to the tolerance. And please note again that when we stimulate on the lower leg, this is not an area where the fibromyalgia patients normally will complain of clinical pain, but this is an area outside the normal pain area. Coming back to the osteoarthritis patients, then what we can see here again is that here we also have reduced cuff pain threshold measures compared to controls. And what was interesting here was that we also assessed this before and after total knee replacement in these patients. And you can see here that before then the thresholds were significantly reduced compared to after they got the knee replacement. So it seems that we can actually normalize the pain hypersensitivity by this knee replacement. I should say that in this group of patients, none of the patients had continuous pain after the knee replacement, which is very often seen in these patients. In 30 to 20% of the patients actually continue to have pain, but in this group they were completely pain-free. So it makes sense. Also in whiplash-associated disorder patients, we had similar findings. This is a study done together with Professor Girdle and Linköping, where we evaluated these patients, exactly the same setup, and here again you can see that we actually both on the arm and on the leg demonstrated reduced thresholds. So this very simple technique seems to be a very nice way to standardize the stimulation and assessment approach, because please note that this is completely user independent. I'm not doing the pressure. This is done by a machine fundamentally. So this is one of the disadvantages with the normal pressure algometry, because this is controlled by the way that you as an experimenter or a clinician actually stimulate with the pressure algometer. So until now, I have focused very much on how can we evaluate the deep tissue pressure sensitivity at different sites on the body. But I also promised that I would like to tell you a little bit more about some very specific pain mechanisms. And the first one that I will try to focus on is the temporal summation of pain. This is a very well-known mechanism in the pain system, and it's simply described by the fact that if you do stimulation to a painful level and you repeat that at a relatively low frequency, then the pain will continue to be the same. But if we then increase the stimulation rate or having shorter time between each stimulation, then the pain will start to integrate or facilitate over time. And especially this increase is highly interesting because it tells us something about how well will the system actually integrate the incoming input, and it tells us how sensitive is the central pain mechanisms. And we have done studies where we have actually used either an automated pressure algometer, as illustrated here, which can do repeated stimulation with 1 second stimulation and 1 second break, and then after that the pain will actually increase over time, even though that each stimulation is exactly the same intensity. And when using such a setup in, for example, the osteoarthritis patients, either on the knee or at the tibialis anterior, then we can see that these patients actually have facilitated temporal summation, so the increase in pain rating is faster than when we compare to controls, or also when we compare to some of the osteoarthritis patients with a less clinical pain intensity. When we do this on the knee, we may not be that surprised that that's the case, but if we do it also at the tibialis anterior muscle, we see exactly the same phenomenon, indicating that the central system is sensitized. We can do exactly the same type of stimulations with this cuff set up here where we can again do a very strong pressure stimulation around the pressure tolerance threshold for 1 second, having a break of without stimulation for 1 second, and then repeat that 10 times. And if we do that in osteoarthritis patients, then you can again see that they are actually very much more facilitated than healthy controls, or actually this is in patients without any pain problems. So we can definitely assess this temporal summation in a standardized way, and we can get valuable outcomes. So temporal summation of pain is one of the things that I would like to suggest to be evaluated, because it gives us some very clear differences of the pain system. Another way to look into the central system is to look at referred pain. Hans Scheibel also presented a few slides on referred pain. Referred pain in the normal condition is completely normal and found in all of us. It's just a matter of the intensity at which it is released. Here you see some examples in healthy subjects where we have injected hypertonic saline into the infraspinatus muscle, and you can see that of course we have pain around the injection site, referred pain to the arm, but also to the frontal aspect, which is very dominating. For many years we have only assessed referred pain by these injection protocols, but now we have also developed a new protocol where we can do strong pressure stimulation manually, and then we can also elicit these pressure pain-evoked referred pain patterns. And this may be a new way that we can actually evaluate these referred pain areas, because as I will show you a bit later, then these areas can be expanded when we look at patients. It's not all muscles where we will see referred pain and not expanded referred pain areas. Here you see some examples where, for example, when we stimulate the triceps brachii muscle here, it's very localized. But again, here you have the infraspinatus muscle giving extreme referred pain areas. And also the tibialis anterior muscle is definitely another site where we see elegant referred pain to the ankle. Other structures can also give either localized pain or referred pain. Here you have a structure that's the infrapatellar fat pad in healthy subjects. When we inject hypertonic saline into this structure, you see a very localized pain area. This may be very unique to the knee joint, because this is also a very typical manifestation of the pain from osteoarthritis patients as such, that it is relatively localized. The sacroiliac joint ligament can also give very pronounced referred pain patterns. Here's again some healthy subjects where we have studied the referred pain pattern, and you can see that you really get this very pronounced referred pain, and it's highly interesting to understand what sort of mechanism is actually controlling that some structures give these very pronounced referred pain areas and others will not. This is asymptomatic subjects. We just stimulate the structures, and we show that these structures are very potent in generating these referred pain patterns. So there are many different ways that we can evaluate referred pain and stimulate and get these manifestations. And if we do that in different patient groups, then we can see that especially the referred pain is sensitive to some of the changes in the central system, because here you see different groups of patients, which has been studied in many different clinical studies. And if you look at fibromyalgia patients and whiplash pain patients and look at the pain areas from a stimulation and an injection of hypertonic saline into the tibialis anterior muscle, then you see that these typically present with extremely large referred pain areas, but also this very well characterized group of patients, the knee osteoarthritis patients, they also demonstrate significantly larger referred pain areas. Not as much as we see from other groups, but there may be a continuum, and also from the low back pain patients it was demonstrated. So referred pain is another way that we suggest that we have a window to understand the central sensitization of the system. The final component that I will try to touch on here is the descending control. And as you know, then we have now been around and looking at the peripheral sensitization, the widespread sensitization, and also some of the central facilitatory mechanisms. And now we should see how we can evaluate the descending control. And it's clear that a change in this descending control will also affect, for example, the hyperalgesia at distant sites, if that's affected. So it's not so easy to say that a distant hyperalgesia is only related to a central mechanism, but it could also be related to, for example, impaired descending control. And the traditional way of evaluating this is by the cold pressure test, where we have strong stimulation on one extremity, for example, the ice-water stimulation, and then we evaluate the pressure pain thresholds before and after this strong stimulation. And in controls, we will see that the threshold, either immediately after this stimulation or during that stimulation, is significantly increased. If we then call in all our friends, or a little bit more than that, here you see a study where we have included a little bit less than 2,000 subjects, then we see that the typical response will be an increase in the pressure pain threshold. Here on these histograms, we have the males and the females, and you can see that most subjects actually have an increase. This is what you see on this side here and this side here. But what is highly interesting is that this is just the healthy subjects that we have called in, but what is interesting is that a little bit less than 8% actually demonstrate an increase. So it's the opposite, or it's actually the impaired descending control here. So we don't know in this study, because it's a very large study, we don't know if these patients or these subjects were characterized with pain or not, but it's just interesting. The normal reaction is definitely that we have an increase. We can also evaluate this by Cuff-algometry, and right now we're running a similar, very large study where we are using this setup, where we can actually do the conditioning stimulation on one leg, and we can do with Cuff-algometry on the other leg the assessment as a test stimulus. And what we see here is that, for example, at baseline, then we have this type of stimulus response function. When we then start to conditioning, doing a strong stimulation, painful stimulation on the other leg, then we have a right shift indicating this conditioning pain modulation. So we can definitely evaluate this. The value of the descending control characteristics is studied in many different experiments. Here you see an experiment where we have looked at what is now the difference between what is happening when we do conditioning pain modulation with the cold pressor test and when we ask subjects to do a strong exercise. This is isometric contraction. And you can see that the exercise-induced hypoalgesia is not as strong as the conditioning pain modulation, but it has the same spatial characteristics. Perhaps the exercise will induce the same kind of descending control, but this is still up for discussion, and I should say that there is a very poor correlation when we look at individual subjects here. In, for example, osteoarthritis patients, Eva Kosek started to show some years ago that the conditioning pain modulation was impaired. This was in fibromyalgia patients, but then in hip osteoarthritis patients here, they were impaired compared to controls, and then after the hip replacement, this system was actually working normally again. And after that, there's been many, many different studies illustrating that the conditioning pain modulation is significantly impaired in many different patient groups. You can see the list here yourself, and this is extended for every meeting that we go for, and you'll probably see new patient groups where this has been demonstrated. Again, just to illustrate the parallel to exercise-induced hypoalgesia and between to conditioning pain modulation, then you here see in a relatively new study where we have taken very generalized pain patients, and we have looked at patients with a low pain sensitivity and a high pain sensitivity. And in the low pain sensitivity, the CPM, conditioning pain modulation, was working very well. This was not the case in the patients with high pain sensitivity. And what was interesting is that exactly the same findings were seen for the exercise-induced hypoalgesia, and here this was also impaired in these patients. So to sum up, then, I have presented you some mechanistic manifestations which can be assessed. I've illustrated something on spreading hypersensitivity. I've illustrated something on how we can evaluate temporal summation of pain, referred pain, and also conditioning pain modulation. And the first three mechanistic approaches here will illustrate something which is pro-nociceptive, whereas the conditioning pain modulation will be regarded as an anti-nociceptive mechanism. We have seen, I've presented to you that the pro-nociceptive manifestations are facilitated in various patient pain models, where they probably have facilitated central mechanisms. And I've also illustrated that the anti-nociceptive manifestations are impaired in chronic pain patients. The big issue right here now is the predictive value of these mechanisms in individual patients. I've demonstrated group data to you today, and what we are of course focusing very much on today is how can we use the individual measure in each patient to describe the pain system. And this is ongoing work, and this is going to be essential. So with this, I would like to thank you for all my collaborators, and I will take questions if any. Thank you.
Can I ask you a question? You
Sure.
usually use also, as we do, the proximal parts of the limb for your stimulation or the body. Did you ever try the small joints? Did you ever try whether the same principles with the large referred areas and so on also apply to finger joints or smaller joints? Because there could be eventually a difference in organization. We never tested by ourselves, so.
It's a very good point, actually. We have never, well, we have done that. We have tried to stimulate some of the intrinsic muscles in the foot, for example, and then we have also stimulated the TA muscle and the vastus lateralis muscles. But I mean, the TA muscle is giving very expanded referred pain areas. The intrinsic muscles will give localized pain areas, but then if you go for the vastus medialis muscle, then it will give less expansion. But I think it's highly interesting to understand why is the knee actually, for example, giving very localized pain areas, and why is the sacroiliac joint ligament giving these extremely expanded areas. For normal ligament stimulation in the spinal cord, we will see referred pain also, but it's still not as expressed as what was seen in the sacroiliac joint ligament. But very good input, thanks. Okay, it seems that there's no more questions, and I also fully understand that because it's time to the break now. We will meet again at 12 o'clock, where we will go for the management part here. So thank you very much.